Welcome back, viewers at home. You're still tuned in right here on Prime Live. We know all stories regarding fighting or rather combating HIV and TB. And I'm quite excited to share a new study that shows tuberculosis patients who receive cash incentives together with counseling have a 52% lower risk of having unsuccessful treatment outcomes. Now, the study was led by Professor Nazeer Ismail and Dr. Harry Moultrie from the National Institute for Communicable Diseases and published early this month in the Lancet Infectious Diseases Journal. Now, for more on what the results could mean for the achievement of a 90-90-90 TB target, I am joined by Professor Nazeer Ismail, who is at the Wits University Department of Clinical Microbiology and Infectious Diseases. Assalamu alaikum and jazakallah so much for joining us.
Wa alaikum salam.
Now, I have to say, this is quite a fascinating study. And I mean, we understand that, with tuberculosis, once you do not take your medication, it forces you to now go into a different regime, which is more costing to the state in that sense. But just as my first question to you tonight, this evening, I would like to ask that this study is quite fascinating and it tells us a lot about, human behavior. Before we get into the details, what really motivated this approach to dealing with the treatment for TB?
Thanks a lot, Memona. So I think maybe there's a few points to note. The first is that tuberculosis is a major cause of morbidity and mortality globally, but also in South Africa. It still remains one of the leading infectious diseases causes of death. So that's the first thing, it's a priority disease. The second issue and sort of the underlying reason for the study was, South Africa has invested a lot of money and effort towards ending TB. And this has included the implementation of really excellent diagnostic technologies, which are available free in the public sector, as well as free treatment. And to top it off all, I mean, TB is a curable and preventable disease. So having all the right ingredients to solve the problem, at least from a biomedical perspective, we're not seeing the same expected effect, despite having all these great technologies. And the thing that sort of struck me the most as we've been going through that has been the issue with loss to follow-up. So loss to follow-up really refers to individuals that on one hand have come forward for testing, but do not return for the results. So that's one group, what we call the pre-treatment loss to follow-up. And the second group are those that do start on treatment, but do not continue to complete that treatment. So those are two groups of loss to follow-up individuals. And the thing that struck me is that we have all these great biomedical interventions, but the challenge has been that there's an underlying behavioral component that impacts on, number one, taking treatment and also completing treatment. And what really spurred me on was when we look at clinical trials that actually enroll patients for specific studies, unlike in the public sector that it's a passive approach. These individuals normally get some payment for their time to come to the clinic and be part of a study. And often they get a bit more enhanced counseling, getting a bit more insight and understanding of the disease. And in those kinds of settings, this loss to follow-up is much smaller. And this was sort of a key take for me was we need to sort of address some of the underpinning problems, not just the biomedical components, but also the biopsychosocial components as well. So that was sort of a key take for me in seeing could we try and mirror that kind of concept in a routine public health service and see the impact of that.
Professor, I had the honor or rather the privilege of just, reading through the article itself. And I have to say, I really appreciate the fact that it was highlighted that most times it's not even about, getting to the hospital, but the cost implication that is not always spoken about when addressing, loss to follow up or, individuals coming in to, follow the treatment in a regime way. I want to find out from you, how prevalent is the loss to follow up among individuals diagnosed with TB who either don't begin the treatment or just abandon the treatment totally?
Right. So it's actually quite common. So the current estimates are around 11% to 25%, so between 1 in 10 and 1 in 4 people would be lost to follow-up. So, I mean, it's quite large. In the study, we had about 16% of individuals that did not come back for treatment in the control arm. So it's not an insignificant problem.
Okay, and then now coming into the results, which I have to say they were quite encouraging, because we understand ultimately the more people come in to get their treatment, the more people who are able to assist in combating TB. It's quite positive for the economy, positive for human quality life. I would like to ask you is, will these results be incorporated into the treatment of TB? And if so, do you think the health department, for example, might implement it even in a pilot project, considering that the Department of Health is facing certain funding complications?
Right. Very good question. So on the one hand, I mean, the Department of Health is quite excited on these results. And interestingly enough, the paper we published in the Lancet Infectious Disease, the commentary was actually written by the National TB Program Manager from the Department of Health. And was actually quite positive in terms of his view and perspective on the findings of the study, and it's created some level of excitement. The underlying factor, and maybe I had forgotten to mention this in the beginning, one of the key aspects that's being monitored globally and also within South Africa is this concept around catastrophic costs for patients. And those costs a catastrophic cost is a household that has 20% of its income being exhausted on medical care. And the recent cost survey done in South Africa showed that 56% of TB-affected patients suffer from catastrophic costs. So I think from a patient-sided perspective, we can clearly see that the impact of care for TB patients is quite significant from a financial perspective. So I think that's the first aspect to appreciate. The second is in terms of a policy decision, is whether something is cost effective, meaning that while it'll cost X amount of money, is the effect actually beneficial and will actually sort of pay for itself? And that's sort of the cost effectiveness. So we haven't published those findings in this article. The work has been gone through and being verified right now. But the early findings do suggest that it is cost effective. So from a where do you put your money effectively? There is evidence to suggest that would be a valuable proposition to actually pay individuals and alleviate some of their costs. And that would actually be quite effective in both the individual patient, but also in the broader community in terms of curtailing transmission. So those are on the scientific basis, I think those are quite strong. And the issue of whether it'll be piloted in the country comes to the next issue of budget. So I know the prior to this whole Trump saga that's been going on for the past few weeks, the DOH had sort of preliminary indications of the results and were very, very keen on looking at piloting the project in South Africa. But in the era of what's happened with funding, I think there's two aspects in my view to this. The one is, often when there's additional initiator funding that comes from grants from other countries, that often makes the initiation of a project much easier, because you might have available funds that could be used to initiate and pilot a project, and then basically look at the findings more in a more routine setting, and then actually in that time work with Treasury to ensure that there's additional funding available to get that implemented. So that component has obviously been affected by these grant reductions right now, or grant cutting. However, I'm still fairly optimistic that South Africa has a relatively strong economy, and I think TB is a priority disease. So I do think efforts towards this will probably take place, but maybe it may be more delayed than it would normally be. I hope that answers your question.
Now, for foresight, Professor, with regards to achieving the TB target, I'd like to just understand in terms of how can this approach, if implemented, help in achieving the respective target.
Right. So there's this 1990 strategy that's aiming to sort of end TB, and that really looks at a sort of a cascade of care aspects related to obviously making sure 90% are identified, diagnosed, and treated successfully. And that's sort of the three components that are sort of targets to achieve that. So this study aims to address one of those 90% targets in achieving a 90% success rate. And what we've seen is that obviously the opposite of success is having an unsuccessful outcome. And what we've been able to show, at least with this study, using both a combination of obviously patient education through counseling, which is largely, been done for HIV for many, many, many years, not for TB. And the second relates to the cash incentives. So these have shown to reduce that unsuccessful outcome by half. And that increment or sort of converting those unsuccessful outcomes to successful outcomes would assist the country in achieving one of those 90s. While it doesn't necessarily reach the 90, at least in the study setting, we know that unsuccessful outcomes vary across the country, but I think as a more broader public policy, it would assist based on this evidence in achieving one of those 90s and getting us closer to ending TB and alleviating some of the challenges we face beyond the biomedical interventions.
Professor, you really clarified me on the idea of TB patients don't really get counseling, because we're under the notion or understanding that when it comes to all things regarding, health and, treatment procedures, there's always that element of counseling the patients. But I'm seeing that the study highlighted the importance of patient-centered approach. I think this now allows a patient to get a more valued treatment and assistance in that sense. Would you say that it wouldn't be wonderful if every public health facility adopted this philosophy?
Yes, it's sort of critical. So, the health service is there to serve patients. That's the whole purpose of a health service, right? And when we look at what we've tried to do, so the patient-centeredness is also looking at not just the biomedical components of giving medication, but also helping patients understand the journey. So the components that we had, the one was around counseling. And it's interesting, often we assume that patients would know and there is information available. But we had sought to ensure that patients, number one, obviously it's busy facility, so we kept our counseling to a relatively short bit of information, very focused, targeted, and had a flyer available as well so that they could go home and read it at their own time. So that really helps. I think, the important thing with health is insight, a patient insight. If they don't really understand why and what's going wrong with them and why it's important to take their medication, then we failed, because we might just be dishing out things that people don't understand. The second is also important for patients to also understand that medication can have side effects and what to do in those circumstances. And that's another issue that was sort of addressed in the counseling, to make sure that, it's quite shocking with one of the medications in the TB regimen, the color of your urine changes, right? To orangish red. And if you're not told that, it could be frightening, right? And it's just simple things like that that are important, number one. So I think that's the one component of patient-centeredness. And I think a lot more around just simple sharing of information and using pamphlets that are quite effective, because people sit and wait for such a long period of time. The second, as I indicated earlier, was dealing with some of the barriers to care. So while we know TB is often associated with poorer incomes and poverty is a big issue, the study wasn't aiming to solve the poverty problem, which is much larger, but at least trying to alleviate some of the financial burden for care. And in that sense, it was giving 150 rand for that visit. So if they did come back for their result, they would get 150 Rand through a digital payment. And each time they arrived for the subsequent monthly visit to collect their medication, when they arrived, they would get a digital payment for 150 Rand. That was really meant to sort of obviate some of the, obviously, I mean, just transport costs in South Africa are not cheap. So just alleviating that, some of the obviously the cost related to their time, etc., and sort of offset some of that. It's not a solution to poverty, but does help with the other financial barriers to care, and really compensate them for their time.
Professor, thank you so much for joining us. And before I end off our conversation, are there any closing remarks you'd like to share with our viewers at home?
Yes, I think, when I look at, our opportunity to do good, and I think, I mean, as humans, our duty is to benefit others. When I look at tuberculosis, it often affects the poorest of the poor. And, these efforts, they don't cost a lot of money relative to the overall cost of health. Um, and really, it can cure and prevent TB and prevent harm and death with very small quantity. We've paid 1,000 Rand to these individuals over the 6-month period, just over 1,000 Rand, and yet made a huge difference in their lives. So for me, this is a good charity in helping others and really alleviating and helping. And I think the circumstances of what's happening with Trump right now and the funding cuts that are going on, I think this is an opportunity for humanity to step up and really make a difference in people's lives. We don't need to depend on big donors. Every one of us could really pitch in to help those in need.
Professor, Jazakallah so much once again for joining us and spending your time and insightful information with us. Jazakallah so much.
Pleasure. Jazakallah khair for the invitation.
Viewers at home, that was Professor Nazeer, who made an amazing study which was just depicting the tuberculosis patients who received cash incentives together with counseling have a 52%, 52% lower risk of having unsuccessful treatment outcomes. Now, do make sure that you go into the journal and look at the study yourself. And after all, you never know. But viewers at home, thank you so much for joining us. Let's head over to an ad break. We'll see you when we come back.